Okay, I believe this is where we left off in our oxygenation lecture. So suctioning, so this is the aspiration of secretions through a catheter connected to a suction machine or wall suction outlet. So like we've talked about with NG tubes, um, there will be like a suction canister that will be hooked up to some kind of suction apparatus, and this is what we'll use for suctioning. So this is just another picture just to kind of help you understand the different types of suctioning that you might do on a patient. And we're going to talk about these different ones as we go along. But there's nasotracheal suctioning, which would be when we would go into the nose and then down into the trachea. You can do oral suctioning, where you just suction out the mouth, or you can do like oral tracheal suctioning. Again, we would go in through the mouth and down into the trachea. And this is a picture here of NT suctioning or nasotracheal suctioning. And we're going to talk more about this procedure, but this is a sterile procedure. Using a catheter to go down through the patient's nose into the trachea and to suction out any secretions and things like that out of the lungs. This is I think it's pronounced differently, but here in Arkansas we call it a yonker. But it is just a plastic piece that you hook up to your suction tubing, and you can use this to suction out a patient's mouth if they're kind of unable to maybe swallow appropriately or whatever. You can kind of use this to help suction the patient out, especially if their level of consciousness is decreased. This is something you're probably going to have and use. Also, if the patient coughs something up, this is good to just get that out of their mouth so they don't swallow it back down. Okay, and then suctioning specifics. So when is it necessary to suction? So when we're going down using nasotracheal suctioning or oral tracheal suctioning, this is when a patient cannot clear their respiratory secretions on their own. For whatever reason, they don't have a good cough reflex, they are weak, they cannot cough up the secretions on their own. So they will likely, their lungs will likely sound very crackly. You may be able to hear it without a stethoscope if they can't cough their secretions up. So this is when it would be necessary for us to suction. So it is a sterile procedure because we are going into the lungs. So absolutely we want to be sterile. And since it's a sterile procedure, we are not going to delegate it to any unlicensed personnel. Okay. Now, if it's just somebody who has something in their mouth and they just need some help with that and you're just using the yonker, that's okay for someone who doesn't have a license to use. But the NT suctioning should not be delegated. Okay, so some important things to remember. So when we are doing an NT suctioning, the catheter size is going to be about a 12 to 18 French. Typically, facilities will have like a little package that comes with the suction canister or suction catheter and everything. It's already sterile. So that's typically what you will use when you perform this procedure. Okay, so important things to remember when we are suctioning is we want to make sure that our patient is in a proper position. So they need to be sitting up and like a semi-Fowler's at least position, and their head kind of turned to one side for oral suctioning. And then the neck should be hyperextended for nasal suctioning, just to make it easier for the NT suctioning to be able to go down. They should, hopefully these patients will have a good gag reflex and all of that, and they're not at risk for aspiration. Then your unconscious patient should be in the lateral position, so the side-lying position and facing you. So this is going to help prevent them from aspirating, and it's going to make the process the easiest. So of course we will have to be hooked up to a wall unit. And when we are doing suctioning, then we want to use, make sure that the pressure is turned up to 100 to 120 millimeters of mercury for adults. Okay, so make sure that you know that. When we are suctioning, we are only going to suction on the way up, and we're not going to suction longer for 10 to 15 seconds at a time to prevent hypoxia. If you are able to hyperoxygenate or give somebody an increased amount of oxygen for that time period while you're suctioning, that is going to be ideal because you are literally pulling air out of their lungs. So if they're already having respiratory issues, which they likely are, this is going to be beneficial to them. Okay, and again, never apply suction during insertion. So this is a picture of the suction catheter for NT or OT suctioning. So it has the catheter and then it has the little suction port up at the top. So when you put your finger over this, this is going to activate the suction, basically. So the suction catheter is here. Once you're inserting it, you insert, and then as you're pulling up, you will intermittently put your thumb down on that suction control port there, and so it's going to give that intermittent suctioning. Okay. This is the wall unit that we were talking about. So you have your meter here, which we would put at 100 to 120 for this type of suctioning. And this is our canister and our suction tubing here. Okay, again, so some more important things. We want to use lubrication for the end of the tube that we're using. And we're going to do water soluble lubricant to make it a little bit easier for the patient, especially if it's going up the nose. We know that's going to be very uncomfortable, so we want to make it as comfortable as possible. And then again, things to remember, applying suction, we only apply on the way up, and only for about 10 to 15 seconds, okay, no longer than that. And how would we know if it was effective? So we do suctioning in order to clear someone's secretions, so their respiratory secretions that they can't clear on their own. So to be able to know if it was effective or not, if we no longer can hear the congestion in the patient's chest, then we know that the suction has worked. So we were able to get those secretions out for them, and that way it's hopefully made it easier for them to breathe. Okay, and this is a position, it's called the orthopnic position. So it's similar to like when a patient will quote unquote tripod or kind of like bend over and have their hands on their knees. So this is going to help patients breathe better, especially if they have like COPD or something like that. Sitting in this position, having the table across them so they can lean forward. They're going to be able to breathe better this way. Okay, so something else that you're going to see a lot in hospitals is an incentive spirometer. If you've ever had surgery, you've probably had to use one of these, but for really any abdominal surgeries or chest surgeries or anything like that, there will be orders for the patient to use an incentive spirometer, and this is just to help improve pulmonary ventilation or help the patient to deep breathe because they're going to be in pain, one. Also, the effects of anesthesia can lead to hypoventilation. So the lungs are not expanding like they should. So then they're at high risk for developing atelectasis and therefore pneumonia. And so we really want to prevent this. It also helps to loosen respiratory secretions, facilitate respiratory gas change, and to expand any collapsed alveoli. Okay, so we are helping them take big, deep breaths. All right, and so these are a couple of pictures of some different ones you might see. The one on the left is one, I know the one they have at St. Bernard's. And So this is just important to know how to teach the patient to use this correctly. Okay, so for teaching, so we want them to sit upright, hold the IS upright or the incentive spirometer. They're going to exhale normally, and then they're going to seal the lips around the mouthpiece. Okay, so the big kind of tube part of it. And then they're going to take in a slow, deep breath and elevate the cylinder and hold the breath for a few seconds. So the cylinder is this little white part here on this one on the left. Not exactly what the goal is on the one on the right, to be honest, because I haven't used that one. But the cylinder, so this is the white part. So we'll have a goal for them on how, how much volume in milliliters we want them to be able to breathe in. And so we'll see how they can do, and we'll document, how many breaths they took in and what volume they were able to take in. Okay. And a lot of patients will want to, blow on it, but they're taking in a big, deep breath. And then after they've done that, they want to hold their breath for, just a few seconds, 1 or 2 seconds, just so you're making sure they're getting that good, deep breath. And then they'll remove the mouthpiece and breathe normally. This is a great time to encourage coughing. So if it's loosened up any of those secretions, they can cough. Then take several normal breaths, and then repeat 4 to 5 times hourly. Okay, so really typically the orders for this is to do every hour while they're awake. Okay, and then after that you want to clean the mouthpiece and allow to dry just to prevent any infection. Okay, so chest physiotherapy. This is another method to help kind of break up the drainage in the lungs. So this is done through percussion or vibration. And it also involves postural drainage, and we'll talk about that. But CPT enhances the clearance of secretion from the lungs through the use of external mechanical maneuvers. Okay. This intervention is beneficial for clients who have COPD, cystic fibrosis, or pneumonia, and for other clients who are unable to expectorate thick, copious secretions or cough up those secretions. The results of this therapy is expansion of alveoli within the lungs, decreased risk of infection, and strengthening of respiratory muscles. Okay. So chest physiotherapy, it's can be used in combination with like breathing treatment, so aerosolized medications, suctioning, and incentive spirometry. These sessions can usually last between 20 to 30 minutes and performed up to 4 times a day. The client is positioned to clear the secretions from the airway toward the bronchi and trachea. So this would be our postural drainage. And then the caregiver's hands rhythmically clap or percuss or vibrate the wall of the client's chest. Okay, so they're just going to percuss on their chest. Usually they do it from the back, just because that's easier. So that's going to help promote good, breaking up secretions, being able to cough them up. And then here's a picture of a nurse just performing this. So they kind of have their hands cupped there, and they're just kind of gently percussing on the back. So this is one way it can be done. Okay, we also want to know how to use metered dose inhalers. Some of our patients will have these, and we'll need to make sure that they're doing it correctly. So what it does is it delivers a controlled dose of medication with each compression of the canister. You must activate the device while continuing to inhale, and be sure to look at the proper technique. Okay, so here at the bottom here, it's got a little diagram of the proper technique. So they're going to remove the cap first, shake the inhaler, breathe out all of the way, then put the mouthpiece in their mouth, Breathe in and press down on the inhaler simultaneously. And then you're going to hold your breath for a count of 10. And then after that, you can slowly breathe out. And that's just to make sure that those medications get into the lungs and do what they're supposed to do. So obviously, these are very common with our asthma patients. Sometimes depending on how severe their asthma is, they'll have one on them, at all times. So, but sometimes other patients who have either respiratory failure, like COPD or whatever, they may have some inhalers as well. Okay, and then there are also types of artificial airways. So these are ones that you will see most often in the ICU or the intensive care unit. This is when someone is unable to adequately breathe on their own and they need an airway. It also could also be because they have a decreased level of consciousness and we're worried about them maintaining their own airway and breathing appropriately. Okay, so this is a picture here of an ET tube or an endotracheal tube. So that has a cuff on the end of it that's inflated to hold it in place in the trachea. And then this is just a picture here as well. So if someone has a tracheostomy where they have a hole that's been made in their neck and they have this tube going into the trachea, maybe they were maybe they had some kind of like spinal cord injury and they can't breathe appropriately, or maybe they just had respiratory failure and they weren't able to get off the ventilator in the ICU, and they had to end up having a trach for long-term care. You will see patients who have trachs. Now, this is not always going to be in the ICU unless they are hooked up to a ventilator, but they can have a trach without it being hooked up to a ventilator. So these are two different kinds that you might see, and we'll talk about these. Okay, so parts of the tracheostomy. So there's a cuff, or not all of them are, but kind of like what we talked about with the ET tubes. There is a cuff on the end of the tracheostomy tube again to help hold it in place. There is a line on it that's like thin plastic tubing that carries air to and from the cuff. So that's how we inflate the cuff, deflate the cuff. There's a cuff port, which is a small plastic balloon-like component at the end of the line. And then there's a Luer valve where the syringe is connected to inflate or deflate the cuff. So that cuff port and Luer valve is talking about this little part here. So this is how they inflate the cuff. Okay, and then there is typically it's a 15 millimeter connector, so it's part of the tracheostomy tube or inner cannula that sticks out of the neck. So this is the part that you will see. The neck flange, this is usually contains the product information and has holes on either side for securing the neck ties or neck securing device. So they will have like a little securement device that goes around their neck and has little Velcro pieces that will go through those holes on that flange and just kind of to help hold it in place. The outer cannula is the actual tube that's inserted into the trachea. So that one will stay in. We won't be removing that one in and out, but there is a cannula that goes in through that. And that is what fits inside the outer tracheostomy tube. And that's what we take out and clean when we do our tracheostomy care. There is an obturator that should be kept, with the patient at all times. And this is just the guide used to insert the tracheostomy tube. So if something happens and something is dislodged or pulled, we need to make sure we have that obturator there at the bedside. So if it does have to be put back in, it can be easily done. Okay, so nursing care of someone with a tracheostomy. So this is in hospital setting, it's a sterile technique or aseptic technique, but patients who go home with tracheostomies, they may use a clean technique. Sectioning of a tracheostomy. So again, sectioning should be done when secretions cannot be cleared, with coughing, or possibly before performing trach care. This is a good time to do it. Kind of same concept as we already talked about with like the NT suctioning. So you'll insert the suction catheter about 4 to 5 inches or until resistance is felt. Pull back a little before applying suction, and do not suction longer than 10 seconds. Pre-oxygenate before, during, and after if you're able to, if it's indicated. Okay, and then care for that inner cannula. So this is the cannula that comes out and cleans. There will still be that outer cannula that will stay in. If they have disposable inner cannulas, so some of them are disposable, some of them are reusable. So if they're disposable, we won't clean and reuse it. Okay, we will just throw it away, and we will not reuse it. The non-disposable inner cannula will need daily or more frequent cleanings if indicated. And we must maintain aseptic technique. You will unlock the inner cannula, and there's a picture of this on the next slide, to remove it, and then be sure to lock it back when replacing it so it doesn't become or start to come out. So on the left here is a picture of a disposable inner cannula. And then this one is the replaceable inner cannula. So you see the outer cannula here, and then the inner cannula you will twist to unlock it, and then pull it out. And then you'll put it back in, you'll twist it to the right to lock it back so that it stays secure. All right, and then securing devices. So down here at the bottom, this is the one you're probably going to see most commonly. Some of them may just have ties, but most of them have little small Velcro ones now, and they just go in the side of that flange, as you can see in that picture. If someone has just got a new tracheostomy, so they've just had the procedure done to place it, be sure to have someone help you secure the device when you change it. And then at the bedside, you always want to have the same size or smaller tracheostomy at the bedside in case something goes awry and something comes out. If there's trauma to the trachea in that area, we might need a smaller size to be able to get it back in there. So that's why you want to have the same size or a smaller one. Okay, so now we are going to talk about some breathing exercises. So this is wonderful for our patients with COPD, okay? So pursed lip breathing, this is going to help them out immensely, okay? So this is typically used to help clients who have breathlessness or feel short of breath. And it may not necessarily be an oxygenation problem, but it could be due to gas trapping that's associated with COPD. So for clients who have chronic lung diseases such as emphysema, COPD, and pulmonary fibrosis, simply breathing can be a struggle. So pursed-lipped breathing is a technique to help with breathlessness. It can be used in stressful situations, during exercise, and during labor-intensive activities. The benefits of the pursed-lipped breathing are both mental and physical. So this technique can help release that air that's trapped in the lungs by keeping the airways open for easier breathing. It can also slow the rate of breathing through prolonged expiration and move air out of the lungs so that the air can enter, thereby improving the breathing pattern. So it's helping promote relaxation, helping get rid of trapped air in the lungs, and it's also prolonging expiration. So that's going to prolong and hopefully increase the amount of CO2 that we're getting rid of, which is an issue with a patient who has these lung issues. So it helps alleviate shortness of breath and encourages relaxation. The pursed-lipped breathing technique is performed by relaxing the neck and shoulders. The client takes a deep breath, inhaling through their nostrils slowly, and then exhaling slowly through their mouth with pursed lips. So you can see in this picture. And you see when, the air's trapped, so you have the alveoli that are just kind of stretched out. And you see how those airways have become kind of narrowed there. So it's hard for that air to get out. But whenever you use pursed lip breathing, it's going to help that air, it's going to help open up those airways. It creates that back pressure. And then that air is going to be able to be expelled from the alveoli. Okay. We also want to encourage controlled coughing and deep breathing. This is going to help also clear any secretions, keep our alveoli open, prevent atelectasis and pneumonia. If someone has had like abdominal surgery or some kind of thoracic surgery, it's really good to use like a pillow or something to splint. So basically they just hold it over their chest or their abdomen before they cough. And this is going to help keep that pressure like from increasing intrathoracic or intra-abdominal pressure that could cause that wound to come open or dehiss. So that's very important for certain types of surgeries that have occurred. Okay, and then this is just a little practice question here. So a home health nurse is visiting a patient with severe chronic obstructive pulmonary disease who is complaining of increased shortness of air. The patient is on home oxygen at 2 liters per minute via an oxygen concentrator with a respiratory rate of 23 breaths per minute. The most appropriate action is to A, call emergency services to come to the home, B, reassure the client of being unnecessarily anxious, C, conduct a further assessment of the patient's respiratory status, D, consider increasing the oxygen to 4 liters per minute. Okay, so the patient, is feeling short of breath, okay, but we need to further assess because this can be something we could potentially help while we're there. It is not, there's nothing here that indicates it's a medical emergency at this time. Telling a patient that they are being unnecessarily anxious is just going to make them mad at you and probably make them more anxious. So that is not therapeutic communication. C, conduct a further assessment of the patient's respiratory status. So this is an assessment. So it's our first step of our nursing process. This looks like a really good answer here. We might check their O2 saturation and see where they're satting. Okay. D, consider increasing the oxygen to 4 liters per minute. Now we already know the patient has COPD, so we don't want to over-oxygenate them. So depending on where our O2 saturation is at, if it's kind of like 88 or above, we probably don't need to increase the O2 saturation. A great thing to do here would be that pursed lip breathing to help with the breathlessness. If y'all have any questions, please let me know.